Now let's classify the AML into various subtypes. Historically, the FAB classification, which was the British classification, has been used for years to classify the acute myeloid leukemia. And based on that classification, it was divided into the various types as M1, M2, M3, going onwards up till M7. That was used for a large number of years. It was very helpful. We had certain important designations, like, as you remember, the M3 subtype, which was defined as acute promyelocytic leukemia. It was one of the commoner subtypes. It has a large number of the granules, the IO rods, which basically define these disorders. And similarly, we had M5 type, which had the monocytic presentation and infiltration into the gums. Recently, this classification has been replaced by the WHO classification. It has made it a bit more complicated, but it basically signifies and it highlights all the important classification, all the important subtypes of acute myeloid leukemia. So based on the WHO classification, we classify the AML into various subtypes as, starting off with the AML with recurrent genetic abnormalities. In this subtype, we have the AML which has arisen from the historically the genetic disorders. The common disorders from which the AML, common genetic disorders from which AML can arise are the Down syndrome, trisomy 21, or the Turner syndrome, which has generally a 45X0 presentation, or Klinefelter syndrome, in which there is an additional X chromosome, and generally the presentation is 47XXY. So we have basically given us a separate classification for AML arising from the genetic disorders. Then there is an AML with myelodysplasia related changes, as we talked about previously, that myelodysplasia can be a precursor lesion to AML. So any AML that has arisen from myelodysplasia previously is classified into this subgroup. And generally, when AML arises secondary to myelodysplasia or other types of disorders like myeloproliferative disorders or paroxysmal nocturnal hemoglobinuria or aplastic anemia, Fanconi's anemia, when the AML is secondary to these disorders, it is generally defined as a secondary AML rather than a de novo AML, which has basically arisen on its own and without any previous history of related disorders. So the important why it is important to classify or differentiate between the secondary types and the de novo types. When we talk about the secondary AML, it generally has a worse prognosis as compared to the primary disorders. These people are generally very old people, and the presentation is generally old because they have a previous years of problems. For example, with myelodysplasia can be there, or proliferative disorder can be there. So over a period of time, they have acquired certain bad cells very quickly. So they generally have a worse or a poor prognosis. Whereas a person with a normal or a de novo mutation or de novo arisal of the AML can generally have a good prognosis if he has certain good translocations as well. So it is important to differentiate primary AML or secondary AML. Then another classification subtype is a therapy-related myeloid neoplasm. This includes basically the disorder that has arisen secondary to chemotherapy or other type of chemical exposure. Certain chemotherapeutic agents like phosphamide and other various types of disorders, unfortunately, while treating cancer, they can also give rise to malignancy. So if AML arises secondary to a therapy, then we classify it as therapy-related myeloid neoplasm. Then we have a sub-classification AML, which is not otherwise specified. This generally includes all the subtypes which are not which do not fit the criteria of the other groups. Then we have a myeloid sarcoma. This can arise as a mass, a small smooth muscle mass, that's why it's called a sarcoma. And this is important because if we have a confined mass, then we can use irradiation to treat that rather than chemotherapy. And similarly, just as we talked about in the start with recurrent genetic abnormalities, Down syndrome patients have a very likelihood of developing AML and also ALL. So that's why for the Down syndrome disorder, even though it is one of the genetic abnormalities, we have given it a different, another separate classification. So myeloid proliferation related to the Down syndrome is given another subtype, and that includes all the disorders and problems related to the myeloid neoplasms arising in patients with Down syndrome. And finally, we have another subtype which is defined as the blastic plasmacytoid dendritic cell neoplasm. So in this, we have various types of plasma cells and dendritic cells present. presenting as the myeloid neoplasm. So this is the new classification, the WHO classification, and it will include the cells with specific characteristics. I don't want you to forget the old classification. Just keep it in mind, the important subtypes present in them. For example, it's very important to keep in mind the M3 subtype, the acute promyelocytic leukemia, for two important reasons. Number one, because it has the largest concentration of the IO rods, which are the azurophoric granules, which we are going to talk about in the coming slides. So it is very easy to identify it because it has a large concentration of those IO rods in that, which makes the diagnosis easy. Secondly, it has a very increased propensity to transform into the DIC, gives rise to the disseminated intravascular coagulation. And DIC can be very lethal, as you all know. And this is the only subtype of AML that can give rise to a DIC that much quickly. And thirdly, we don't treat that acute promyelocytic leukemia, which is also designated as APL, with classical or standard chemotherapy. We use vitamin A. We use a vitamin to treat a neoplasm, which is basically fascinating. So we use ATRA or all-trans retinoic acid for the treatment of acute promyelocytic leukemia, which is also subtyped as APL. So it is important to keep that in mind because that classification made it very easy to remember. With this new classification, there is somewhat confusion with the overlapping groups, but keep the new classification in mind and follow the new classification protocol, but also keep the important points of the older classification in your mind.